Hey students, you're listening to the lecture on assessment and management of patients with obesity. The objectives are for you to be able to describe the causes, classifications, and diseases and disorders associated with with obesity. Identify strategies aimed at preventing and treating obesity, including lifestyle modification, pharmacological therapy, and non-surgical interventions. Explain nursing management considerations for the patient with obesity using non-surgical interventions. Compare and contrast surgical modalities indicated to treat patients with obesity in terms of pre-op, post-op, and long-term management and complications. And use the nursing process as a framework for care of patients who undergo bariatric surgical procedures. The rates of obesity in the United States as well as globally are staggering. If you look here, 68.5% of American adults are considered overweight or obese, and the number of children who are diagnosed with overweight or obese is increasing significantly. Increased risk for disease, disorders, low self-esteem, impaired body image, depression, and diminished life quality go along with the diagnosis of obesity. However, the cause is not easy to identify. It's complex and multifactorial. It can be behavioral, environmental, psychological, physiologic, and or genetic. So it can be all of those. It can be a combination of those. They're not really sure. But no matter what the cause is, we do know that obesity is a chronic relapsing disease that is characterized by excessive accumulation of body fat as well as weight gain. The increase in body fat causes adiposopathy, which causes the adipose tissue cells to release biochemical mediators. This causes chronic inflammatory changes and leads to a multitude of diseases. Obesity is associated with a 6 to 20-year decrease in life expectancy. The risk for cancer increases with increased BMI. Likelihood of type 2 diabetes is increased by tenfold. Asthma and hypertension are by fourfold, and the patients are twice as likely to have hypertension. And this comes from your book, but it's just a picture showing all of the different effects that obesity has on the different body systems. Height and weight measurements are used to determine the person's BMI. Those with android obesity, or what you might have heard as an apple shape, so people can be defined as apple or pear-shaped. If you have an apple-shaped or android obesity, then you have a greater risk for hypertension, coronary artery disease, stroke, and type 2 diabetes. There are different classes. There's actually 4 classes, the first being pre-obese or overweight, and then class 1, 2, and 3. They're all listed on the slide. You can also look at waist circumference and the waist to hip ratio to determine obesity and the severity of their weight gain or overweight or obesity. You're also going to look at cholesterol levels, blood glucose, liver function, A1C. They need to modify their lifestyles, and we'll talk about each of these coming up. We're also going to talk about pharmacological treatment, non-surgical, and surgical treatments. Weight loss of as little as 5% of the total body weight can result in significant clinical improvement and benefits. So when patients are looking at how much weight they need to lose and their ideal body weight, you should start small and let them know that, as little as 5% can help them significantly. So they don't have to look at, maybe they have an overall goal that is larger, but they can start with a smaller goal, and then they can work their way up. Patients are instructed to plan a calorie deficit of between 500 to 1,000 calories daily from their baseline to achieve 5 to 10% reduction within 6 months. This is done both by decreasing the caloric intake and increasing the activity. They should have a daily journal, 24-hour recalls, dietary interviews that can all be used to figure out their baseline dietary habits and get an idea of what their current caloric intake is. As far as exercise, at least 150 minutes of moderate intensity aerobic exercise a week should be the goal. So moderately intense aerobic exercise, that is different for different people, but they should be breathing heavier, they should have a higher heart rate, but they should still be able to talk. Many people with a sedentary lifestyle need to start small, work towards that goal, and so they don't want to harm themselves, especially if they're really sedentary. So their exercise might start with more light weights, range of motion, simply walking short distances because that's all they can tolerate. But as long as they're doing something more, they're getting their heart rate up, they're getting their circulation moving, and they're being more active than they were before, they will slowly be able to build up to more strenuous activities. There are several commercial diet plans that are out there. They are available. They do work as long as they're being followed, but they're not necessary. And they haven't done any research to say that one's better than the other. So if you talk to a dietitian, they probably will not recommend one over the other, and they'll be able to tell you which ones to avoid. But that's basically it. However, they don't need to purchase the plans in order to lose the weight. They can just focus on healthy eating habits, and they can work with a nutritionist or dietitian on that. There are medications that can be helpful, but they don't take the place of healthy eating and exercise. So if healthy eating habits, exercise hasn't helped in the past, they need something to supplement that, and to help with that, then they can take medications, but they're not going to take the medications and then go back to the way that they were eating and the sedentary lifestyle they had. The physicians won't approve those medications if that's what happens. They have to have a BMI over 30. They have to have tried other diet and exercise that doesn't work. They can have a BMI greater than 27 if they have comorbidity as well. As far as non-surgical interventions, those who have been determined to be a candidate for bariatric surgery might opt to choose the minimally invasive interventions over the full surgical intervention. And the minimally invasive ones are the vagal blocking and the intragastric balloon therapy. Vagal blocking diminishes gastric contraction and emptying. It also diminishes pancreatic enzyme secretion and limits ghrelin secretion. This causes a feeling of satiety, decreases cravings, it also will diminish the absorption of the calories. The intragastric balloon therapy is thought to increase the feelings of satiety as well, and decreases gastric emptying. That's how they're supposed to work. The gastric balloon therapy, though, does come with some complications because the balloon can rupture. Obesity can cause compression of the oropharynx, and it can increase neck circumference and chest diameter. This will predispose the patient to obstructive sleep apnea, respiratory failure, obesity, hypoventilation syndrome, which is daytime hypoventilation with hypercapnia and hypoxemia. Patients can also have decreased circulation, compromised peripheral blood flow, hypertension, heart failure. Effects of medications can be affected by the ratio of lean skeletal muscle mass to adipose tissue, so obesity can either increase or decrease drug metabolism. Patients with obesity are more vulnerable to pressure ulcers, and this is because they have increased adipose tissue that will diminish the supply of blood, oxygen, and nutrients to the peripheral tissue. They also tend to be more sedentary. They have more folds in the skin and increased skin moisture, which can increase the chance of infection, yeast infections, and it can also increase the skin breakdown just from the moisture in the folds. So when they're bathed, you need to make sure you really clean those folds out and make sure they're completely dry. Otherwise, just bathing and leaving the moist skin in the folds can cause skin breakdown, even though you're trying to help. They tend to be less mobile, and they tend to need special bariatric equipment. So they'll probably need a bariatric bed, bariatric commodes. They'll need a larger walker. If they need a walker, they'll need a bariatric wheelchair. There's also special equipment that is made to help turn and reposition so that the staff don't injure themselves with proper body mechanics. To help with ventilation, make sure that they are in a low Fowler position, so don't lay them completely supine. They can get supplemental oxygen, and if they have obstructive sleep apnea, they can have a CPAP machine. Make sure the blood pressure cuff is an appropriate size when you're getting their blood pressure, and you might have to get it on their wrist instead of their upper arm. And then they should be on some sort of anticoagulation therapy, and you need to monitor to make sure they don't get any blood clots. Again, some will enhance and some will diminish as far as drug effectiveness. So they might need more opioids for pain relief, but they'll need less norepinephrine. And those are just examples. There's other drugs that are affected as well. When you have weight-based calculations of drug doses, those might need to be altered as well, and you can work with the doctor and the pharmacist to figure out what's the best dosing for the patient. Assess for pressure ulcers, even if it's difficult for them to turn and reposition. The patients that are the most difficult to turn and reposition are the ones that don't move that much, and those are the ones that you really need to watch for. So you're going to have to look for the pressure ulcers, and then also look in between all of the folds under the breasts, between the scrotum and the thighs, and then lift the tip of the penis to make sure that there's no pressure between the penis and the scrotum, because for men that can be a cause for breakdown as well. As far as bariatric surgery goes, there is a preliminary process, and they do have to meet certain guidelines. So they'll get months of counseling, education, and evaluation by a social worker, dietitian, a nurse counselor, a psychologist, or a psychiatrist, and a bariatric surgeon. And that's because they need to be able to follow the rules afterwards. Otherwise, they can have pretty significant complications. So they need to show that they can change their lifestyle, and they have to show that they're committed to the change in lifestyle, and that they're going to follow doctor's orders before and after the surgery. They also have to have a BMI of over 30. They can have they look at their comorbidity and the other diagnoses that they have, chronic conditions that they have, and they can lose up to 35% of body weight within the first 2 to 3 years, which is a significant amount. Most of them, because of a significant body weight decrease, will have to have some sort of skin surgery, because a lot of their skin will then sag, and they'll have to have that excess skin removed. The different procedures as far as surgery goes, there's the Roux-en-Y gastric bypass. That and the gastric banding are the most common. And then the biliopancreatic with the duodenal switch leads to more weight loss. It's more common in patients with very high BMIs, but it's usually reserved for those that have the really high BMIs. And then there's the sleeve gastrectomy. And these can be performed laparoscopic, or they can have the open surgical technique. It depends on the patient and their situation as to which would be better. Laparoscopic generally is better than open surgical technique, but it's not always possible. All right, so the Roux-en-Y gastric bypass is restrictive and malabsorptive, which is important to know. Some of them are just restrictive, and then some actually have malabsorptive properties to them. And this might require extra supplementation as far as vitamins and minerals, whereas just the restrictive surgeries don't necessarily require vitamin and mineral supplements. Gastric banding is just a restrictive procedure. So you see basically what they're doing is they go in and they put the band around, and that's going to limit the amount of food that can be held before you feel full. And then they can have vertical banding, which is a little bit different. They can have the sleeve gastrectomy. They can take up to 85% of the stomach. And this is restrictive as well because they're removing most of the stomach. They call it a sleeve gastrectomy is because it looks like a sleeve. That's the only reason. They don't like actually go in and put a sleeve in there. It just looks sleeve-like. That's where it got its name. And then the biliopancreatic diversion with duodenal switch is right here. And it's a pretty complex procedure. It is restrictive. Obviously, they take part of the intestine out. But then it also is malabsorptive as far as the intestinal absorption goes. So this will also need some sort of vitamin and mineral supplementation. As far as pre-op, assess for any contraindications of the procedure that they're going to be having. Make sure the patient has been counseled, make sure they've been educated on what to expect long-term and short-term. You'll look at their CBC, you'll get a BMP looking at their electrolytes, their BUN, their creatinine. The patient needs to be stable with their other chronic illnesses or they won't be able to have the surgery. Post-op, set specific goals, make sure the goals are met. You're going to follow your ABC, airway, breathing, circulation. Make sure they don't have any complications. Assess the surgical site, so it's just anything that you would do for any post-op patient. Coughing and deep breathing, so that they don't get atelectasis or pneumonia. Patient will be on a PCA for pain control immediately post-op, and so you need to educate them on the use of the PCA. They will be on IV fluids post-op, and they will stay on the IV fluids until they can't tolerate liquids. They will be given sugar-free liquids, and that's because sugar tends to increase the chance of dumping syndrome, so that's why they'll be on the sugar-free. They'll be on a liquid diet before as well as after surgery. And then the bariatric diets follow a progression. They'll go from clear liquids to full liquids to soft. They can only consume 600 to 800 calories in one day. And the amount that they consume at one time is extremely small. Progression of the diet is very slow, and this is to maximize the weight loss and prevent complications. Electrolyte drinks are needed so that they can supplement their electrolytes while they're on this restricted diet. And then diets high in fiber can help with diarrhea. It's common with the malabsorptive surgeries, and then vitamin supplementation for malabsorptive surgeries as well. Obviously, the high fiber diet is going to be once they're able to have their soft diet, so once they've progressed. It's also going to help with constipation and diarrhea. Intra-abdominal hemorrhage is one of the complications. It can be early on, it can also be later. The patient can have frank, bright red bleeding, and they can vomit the blood, or it can be from the rectum. They can have tarry stools as well. They can have bloody output from the wounds or drains. Other signs of hemorrhage would be a hemorrhagic shock, especially if you're not catching the internal bleeding signs and symptoms. Bile reflux can occur with procedures that manipulate or remove the pylorus and can cause inflammation of the stomach or esophagus. And so the patient might complain of epigastric pain, and then they'll have vomiting of the bilious material.